We know that adoption for measurement-based care is between 17 and 22% based on studies out there. Can you talk about learning about measurement-based care and what ultimately drove you to adopt it?
For a long time, I think there was debate in the field as to what are the standardized measures, whether they can be done, whether they should be done by the scales or measures that we'll use for measurement-based care. And everybody is in agreement that these things are a good way to monitor care. And then the technology, I think it's really about like having a conversation with clinical leadership and a top-down approach that, listen, we believe in measurement-based care. We know that your setting is unique. What works for you? And let's see how we can build a culture of continuous performance improvement in your clinic, and what a great way it would be to start measuring outcomes. Because unless you have the outcomes, you don't know how you can improve things.
Welcome to another Meeting of the Minds with Northwell Health. I'm your host, Chris Hemphill, and I'm excited, and I'm a little bit overly caffeinated, but we're reporting from the Future of Mental Health Conference. You might have heard us saying that over and over again, and the excitement just comes from the lineup of speakers and guests that they brought today to talk about some of the most important and impactful issues in behavioral health. But with the future of mental health focus, we're talking about the obstacles that exist today, but with optimism and persistence, how we can overcome them and create a better future. Part of that future is it's in the sole hands of Dr. Manish Sapra today from Northwell Health, who is the Executive Director of Behavioral Health and Psychiatry. I got that right? Excellent. So we're going to delve a little bit deeper into measurement-based care, but before we jump in, Manish just wanted to give you the opportunity to say hello to all the folks watching.
Hi, so excited to be here. It's a great conference and great conversations happening, and hopefully this will be another good one too.
Excellent. Well, thank you. Really enjoyed seeing you speak and seeing your panel, and unfortunately, not everybody who is watching was able to be there. So I see this as an opportunity to go in deeper, where if it's an hour-long panel and you only have 20 minutes of speaking time, we can get really deep on the subject and topic here. Just kicking it off, I'm going to admit I'm a newbie when it comes to the digital mental health space. I've started in May 2022, and when I first started, having a background in tech and healthcare analytics on a lot of electronic medical record data, I was actually surprised. I wasn't prepared for the amount of contention and debate that comes with the idea of measuring outcomes on a consistent basis. It was a completely alien world to me. But since then, I've learned that measurement-based care has actually been proposed since the 1980s, and at the same time, we've done several episodes on it since. You can hear from Dylan Ross, who sits on the American Psychological Association as the chair of the Measurement-Based Care Committee. You can hear previous episodes with Melissa Riley for the payer perspective, as she's the chief strategy officer at Evernorth. And most recently, we did an interview with Dr. Maria Koshy at Kaiser Permanente, who, when we asked this question about a magic wand, if you had the power to change anything in healthcare, what would that be? And she said consistently measured outcomes across payers, providers, et cetera, for a consistent approach to measurement-based care. So we're going to get into it. We're going to get into the fundamentals and basics. Manish said something that really stood out to me. It's a really simple sentence, but he said, I just see it as good clinical care. So rather than trying to unravel all the ideas around incentives and sticks and carrots and things like that, we want to get it down to the fundamentals on what makes measurement-based care an effective clinical practice. And then we're going to blossom it up into the business opportunities and growth opportunities that opens. With that, Manish, would you care to do an intro to yourself and Northwell and just ground folks in overall how it's used in your organization?
Sure. Yeah, I'm Manish Sapra. I'm a psychiatrist. I have been doing this much longer than what you said. My background is in community psychiatry and population health. Early on in my career, I got interested in just the administrative aspects of psychiatry. There's when you go into the field, you obviously want to help others, and there is something about healing that draws you. But as I saw the mental health care delivery system, I just felt like I could make a bigger impact at a system level where if you made some changes in how care is being delivered, how your intake process is, what is the quality of services that are being delivered, you just impact so many lives. It's not just one person at a time. So that drew me to administrative work, and then to community psychiatry, which is basically serving underserved and being working in the community-based organizations. From there to population health, and now I work in a large health system where I've been with Northwell for 7 years. I started out in population health and have been the executive director for their behavioral health service line for the last 4 years. Northwell is a great system, great place to work. It's a very large service line. We have 2 freestanding psychiatry hospitals, but also several inpatient settings in many of our community hospitals. So we're total 600 beds in the system. We do more than 250,000 outpatient visits per year. Large outpatient program. We have a great teaching program. We have 3 residency programs within our system. So it's a large enterprise, and every day I come in and I'm just so lucky to be able to work and influence care at a broad level. So talking about measurement-based care, this is really, its roots are also in community psychiatry and population health. And it's really measuring impacts at a large level, so that there can be a clear vision into the quality of services that are being provided. But I think at an individual level, right? It's as we said earlier, it's just a great way of getting feedback on how you're doing and improving the therapy process, or improving the any care process that a patient may be engaged in.
So I think that gives a great ground to start, where we're focusing on that individual care practice level. But I just see it in your thinking, and what's attracted you to administration in the first place is you're thinking broad scale as well. Yeah. So taking the advantages from that practice at the individual level, and then seeing what that looks like when we're approaching it and applying it at scale. So that provides a great foundation for us to, I like the way that you framed it up at the individual level, and then blossomed it up to how it can affect positive outcomes from an organization at the population level. And anybody who's listening closely can kind of hear that. Like, we know that as a psychiatrist working one-to-one with patients, there's a passion there, and not forgetting about who all of this is for, the patient. And what's attracted you to administration, wanting to affect change broadly at scale. I think this is going to be a very good place to dig into that conversation. But before we do, I know that these conversations can be between 30 and 60 minutes. But if there's only one thing, like if somebody was to turn it off right now and only know one new thing, what would be the one thing that you'd want somebody to walk away with after listening to this?
About measurement-based care?
Yeah.
Well, I think I see that one big thing, or one big theme about measurement-based care is that a practice or a setting that has engaged in implementing measurement-based care is focused on providing good quality care. And now from there, we can talk about why that is the issue, not the issue, but how that leads to good quality care. But it is certainly an investment in quality of care. I guess that's the one big thing I would say. Now, it could be because we want to know if our treatment is working, and that's why we set it up. It could be good quality of care because it is actually an intervention when patients are able to see what symptoms are trending down, what symptoms are not trending down or going up. Then treatment can be targeted or modified because of that. And thus, it can become like not only a proof of good quality of care, but actually a tool to actually provide care, right? And it may also mean that a clinic, which may be financially incentivized because of they may be in a value-based purchasing agreement or a pay-for-performance agreement with a payer, that they are really looking to provide the best care that they can. So overall, it's a great sign for good quality of care being provided. So it's that's one thing to take.
So, and framing it in that way, I think that lists kind of an objection that a lot of people have to it, which is often they'll view it as an administrative burden and data collection burden because it's not framed up in a way that gets them to focus on its ability to actually impact outcomes. That it just often comes off as a tool for driving financial incentives for someone who's not them.
Yeah, and listen, a lot can go wrong in implementing measurement-based care. And there are a lot of good reasons that people have, or when they'll raise a voice against it. So one of them is the big thing is the administrative burden, right? The providers, the administrative burden on the providers is already very high. So we should be doing everything to cut down that burden, right? That's part of our quadruple aim, right? To improve quality of care, decrease cost of care, to improve providers' satisfaction. Also, as we are trying to improve quality of care and decrease cost of care, and of course the patient engagement, right? We want to work on all, and so if we build measurement-based care where either the patient experience is not good because now they have to fill out these forms just to get into the therapy session or to see their doctor, that's going to cut that down the patient experience and also the provider experience. So it has to be built in either with the use of technology or in the workflow, as I said, as a part of the treatment, so that everybody's engaged and does not either see it as an administrative burden or is not purely an administrative burden. The other issue about measurement-based care is it does tend to, in some people's minds, oversimplify things, right? So, we are all complicated individuals, and of course, our patients have multiple things going on. It's very common in our clinics to get multiple diagnoses. So, linking measurement-based care to one symptom or to one disease. So, somebody may have depression, but multiple other things going on, and just following their PHQ-9 scores, which is the depression monitoring scale, may not be, maybe just a step towards oversimplifying things. Well, your PHQ-9 is going down, so you must be doing better, and that may not be the case in that. So it's also important to use measurement-based care, but in the proper context, as an additional tool to the clinical care that is. It's not a replacement of clinical care. It is also not now a way to protocolize things and put them in an algorithm and let a machine sort of handle it, like, because your PHQ-9 scores are trending down, and then maybe your dose of this medication should go down, or your therapy sessions should be further apart. So, or you can get therapy from somebody who may not be that skilled. Those kind of things, those are some dangers of implementing measurement-based care. I hope I'm answering the question that you asked.
You are, and you're painting a picture because, listen, when people heard the intro and we were talking, they knew that it would be a pro measurement-based care conversation. But I said optimism at the beginning, and I believe that optimism is more than just a feeling of thinking things will go well. I think it's a responsibility. Like if you just think that things will go well and leave it to the wind, then you don't know what's going to happen.
Yeah.
But I think a good optimism is to go into it understanding what those dangers are, what those cautions are, especially for the people that don't have this implemented in their organizations but want to. Like I asked you what you wanted out of the conversation. I want people to look at this as potentially a blueprint to like just give a guide and overall idea on how to help enable this in their organizations.
Yeah, and I think that's why I mentioned these things, because you really want to go with the right why or why are you implementing. And I think if the why is we want to do good clinical care, because there is so much evidence that measurement-based care is actually good clinical care, and we have the technology figured out, we have the workflows figured out. It's not going to be the administrative burden. We're not going to be using measurement-based care to other things, or let it slide into a different level of care, as I was talking about, or we're not doing it as a reaction to some regulation or a P4P arrangement, or as an administrative burden. I'm sorry, that's when it will be seen as an administrative burden, and we just do not want to implement it for that reason.
So maybe we can rewind a little bit to the time that, because like we know that the adoption for measurement-based care is between 17 and 22% based on studies out there. But that means that there was a time before you were aware of measurement-based care, and in your practice you began to incorporate it. Can you talk about learning about measurement-based care and what ultimately drove you to adopt it?
Yeah, I mean, I was talking about this in our session. We've been talking about measurement-based care for some time now. You mentioned, that the concept coming out back in the 80s, but really for a long time, I think there was debate in the field as to what are the standardized measures, whether they can be done, whether they should be done by the scales or measures that we'll use for measurement-based care, whether they will be done by the providers or whether they be done by the patients. So I think it took some time for the field to have standardized measures that could be done by the patients, and that we feel comfortable about it, and everybody is in agreement that these things are a good way to monitor care. And then the technology, right, like electronic medical records, patient portals, handheld devices where people can actually, or kiosks where people can fill out these forms, that developed. So patient-generated data that can go to our electronic medical records, it took us some time. But I really thought that back in like 2015, 2016, maybe 2017, like we had figured all that out. But it's really been not that widely implemented as we all thought it might be. And we can certainly talk about, I already talked about a few things that are the barriers for that, but it should be, we should be figuring out how to implement and build measurement-based care in our programs now, because I think many of the things that were needed, the framework for it, were solved some time ago.
So there's a big foundation out there. There's lots of materials and evidence that people can draw from to bring that into their own practices and context.
Yeah, absolutely. And I think it's really that at this time it is about the why, right? So I think one of the main issues has been the clinicians may still not have knowledge of all the evidence that is there for measurement-based care, and may not feel like that, everybody likes the care that they're providing. They think that they're providing good quality of care. Everybody feels like their patient panel is different. Is the more it's these you don't know, like, as we were saying in the panel, our patients yet. You should see. So everybody feels like that their setting is unique, and may have its unique challenges, and then just using some scale that comes from top-down approach may not be the best implementation, in their setting. I think it's really about like having a conversation with clinical leadership and a top-down approach that, listen, we believe in measurement-based care. We know that your setting is unique. What works for you? And let's see how we can build a culture of continuous performance improvement in your clinic, and what a great way it would be to start measuring outcomes. Because unless you have the outcomes, you don't know how you can improve things.
So, yeah, to take away from the idea that it's always going to be some top-down initiative or always going to be based on financial incentives that the clinician doesn't benefit from, how would you define, what's the ideal way to really define what measurement-based care is at the very baseline?
Yeah, well, measurement-based care, just the definition of it is some kind of a routine monitoring quantitatively of the symptomatology that is being treated in a clinical setting, right? Now, we do this so much in physical health. You go in to see a doctor, you get a blood pressure monitoring, or you get some labs. So either through labs or through getting on a weighing scale or through a blood pressure monitor, you get some value that we want to treat, that we want to trend, that we want to make sure is in the range that we would like to see it. In behavioral health, we really don't have labs that other than monitoring, drug levels for some of the drugs that we provide to our patients. There's not much we can do to really measure the symptomatology unless you're using some standardized scale and can come up with a value that can be assigned to the severity of the illness. So that's what measurement-based care is.
And I'll ask that and then want to build into that. So we've been talking about the fact that it is good for clinical care and practice, but can you tell us why measurement-based care it results in effective care?
Yeah, so I think just the element of implementing measurement-based care leads to data, right? And that people can react to or respond to and modify the treatment so that hopefully it leads to a better response in clinical condition. That sets up a culture of measuring outcomes. And once you have the outcomes, you can constantly think about, well, what the treatment that we're providing, is it effective or not? So it's that, right? It's just measuring outcomes. The second piece is it's also, as I mentioned earlier, an intervention because it helps having that conversation with the patient as to, we've been working on these issues. Let's say somebody's suffering from depression, but they also have insomnia. So maybe the depression is trending down, but not insomnia. So what can we do to help you with this symptom, right? So that the treatment can be modified as we're going along because of the feedback that we're receiving from these from patient-reported outcomes. It can also be a memory for the patient. Sometimes we say that the therapists are the memory of the patient during the treatment because we go through a lot. We're going through a tough time in our lives. So it's, just knowing that I was here 6 weeks ago and now I'm here, just seeing that trend or seeing that feedback in itself can be therapeutic to the patient. So there are multiple benefits of measurement-based care.
Excellent. And yeah, I strongly agree. Anybody who is watching and has used a mood tracker app or like you use the applications to measure yourself, if people are willing to measure themselves, then like being able to share in that memory and transparency in their own history, I think is empowering.
Yeah, and just having a record of it, and this is not usually studied about measurement-based care, but if you have a solid evidence that you went to treatment and it worked, and then a few years later you may need it again, at least you have that memory that you went there and it worked, so you may go back again to it, because otherwise we forget that we did seek help and it worked.
Yeah, that's like somebody's looking back at their older entries or information and sees that they could be seeing that at the right time that they need it. So thinking at that organizational level, you had mentioned cultures of measurement and like the ability to potentially help use data as a guide. who are like imagine that you're at an organization that hasn't embraced measurement-based care, but you know what you've learned from seeing the people who've adopted it and spread it throughout the other teams. For the folks out there that are trying to grow this measurement-based care practice, who are the types of people, coalitions, and efforts they should take to start growing?
Yeah. Well, I think, I work in a very large organization, and I often say, the culture cannot be centralized, right? We cannot do everything. And we say, we have this culture of doing this and this, and these are our values. So you and that sitting in that clinic, in that hospital, are going to also do this because that's our culture. It's hard to band-aid things that way. But I still think that the senior leadership can really be a voice in setting up the values. But I guess the job of leadership or leader is then to translate that value into how the clinical workflows work for that practice and what works for them. Because ultimately you have to be in the shoes of those clinicians at that site and understand the patient population, the resources that they have, and what they can work with or not before you mandate something, right? So for me, it's always finding the why for that clinic or that setting, rather than mandating that this is what we're doing something system-wide. Now we do something system-wide. We do, like, for example, we're right now doing a depression screening initiative, which is going to be available for some 2 million patients who come to Northwell. So we're going to screen everybody at least once a year. And those are some system mandates, and I think those are good exercises. It just creates a culture of screening and creating a value within our providers that we care about this, and we have abilities to treat, and we have good treatments available. I'm going to screen people. I'm going to treat them. But when it comes to more complicated stuff, I'm not saying measurement-based care is complicated, but actually developing more in-depth workflows within a clinic, it is really going back and talking to the clinical leaders, saying, okay, how can we help you create that culture of continuing performance improvement at your site? And I think people will come up with what will help for them. The other piece is there are a lot of clinics that want to show their outcomes because they're either doing specialty care, we have an OCD center, and they may want to clearly monitor their outcomes because they care the value about it, and they have to, and they feel like this is helping their patients. There may be scholarly activities going on, research-based activities going on. So you certainly want to find the sites which may be warmer to the ideas and start there. One of the great places for us where we've been able to implement measurement-based care is our population health programs, right? So collaborative care, which is integrating behavioral health and primary care, you have to do measurement-based care. You cannot do collaborative care without measurement-based care. So we do PHQ-9 scores every month. Everybody who's enrolled in the program is in a registry. We train them out, and we do psychiatric consultations based on patient scores. So it's really great program that we've been able to build at Northwell, which uses measurement-based care. We have a digital application that we built to provide psychotherapy services. And we are able to, through that web-based platform, send patients forms, and they fill them out, and it's a big part of how psychotherapy is given through that program. So those are some good examples of how we have implemented measurement-based care.
There's some helpful themes that come from those examples. A lot of them based on, rather than mandate, it sounds like you mentioned some of the hurdles and roadblocks, and it sounds like mandating versus listening and partnering is one of those hurdles and roadblocks. That a big theme is for a senior leadership team to go down to an individual population clinic and work side by side rather than it just being a measure that comes on high.
Yeah, it's just that's when it feels like an administrative burden when you do it that way, and so I think one can mandate or may not mandate, but just create a culture like we are about quality. We're about continuously improving our practices. We are about evidence-based practices, and we're a clinical setting where we give cutting-edge treatment. And this is cutting edge, and it's good quality. I want to build it in. So let's sit down and see how we can do that. You know.
So I'm asking selfishly, one thing that helps me like really understand and personify how something works is like, of course, I lean on spreadsheets and everything like that, and data sets and things. But what about, are there any stories that come to mind of patients who were uniquely helped by measurement-based care that wouldn't have been able to have seen that improvement and seen that outcome under the older paradigm?
So I'm not myself doing primary clinical care at this time, but I can tell you what I have heard from my clinical team. So we built this web-based platform. We call it BeHealth. It's a way to provide virtual therapy and we primarily use it for employees of Northwell at this time. It's and the whole therapy is manualized and is based on principles of cognitive behavioral therapy. So we not only do measurement-based care, but we also do these workbooks, and patients have to fill out their homework. It's been such a great pleasure to set up that program and to just hear the stories of patients who are actually benefiting from that has been such it's one of the better things I've done in the last couple of years. I feel like that team that we hired to develop that platform and to build this really outcomes-based program right from day one.
Mm-hmm.
And we're actually measuring outcomes. We'll be publishing it. It has been this great journey of actually not only just creating an evidence-based program, but actually quantifying it and showing that evidence-based program is better than treatment as usual. We have great engagement of patients coming on an average for about 12 sessions, actually sticking with that, right? And the modal treatment sessions out in the community is one, maybe two therapy sessions that people on an average come to, right? And then being able to monitor their symptoms using these scales and seeing a significant improvement in depression scores, with significant people going into remission and response. It's been great. So, and a lot of feedback that we've got from the patients is really about how, looking at those dashboards and seeing how they are trending. We also use some other engagement techniques like sending them text message supports and all. It's just been a great way of providing treatment that really works. And I feel like, a lot of it is measuring outcomes and monitoring them.
So when this new tooling and capabilities and cultural practice was released, patients got their own view, their own transparency into it, and they're responding and saying, hey, I like the idea that I can finally look at this over time and have have my own over time trended view into how I'm doing.
Yes, and we launched it about 1.5 years ago, and it's just like we don't do much advertising, and we've had more than 700 patients come through the program. It's been and just the positive feedback from them. It's just been great.
And I know it's sensitive information, so it's okay if not. But are there any feedback or stories that you've seen that come to mind that resonated with you?
The most that I get is, because this is mainly for the employees of Northwell, so I run into them in gatherings and events, and then just people coming in and reaching out to me, just saying that the skills that were taught to them during therapy sessions or how they, and the work that they were made to put because the patient has to put the work in, right, to get better in the sessions. That even some of them are in mental health space themselves. They didn't believe in it, right? So I think it's the belief in those sessions and the power of that treatment works. Just seeing that in their eyes when they talk to me about the renewed confidence, like what we do actually works, and because it worked for me, it's like that's really good to hear.
So we've talked about unlocks for care and things that are unlocked for business capabilities as well, such as integrated health and value-based care that require measurement as a foundation. It does make me wonder, like when you defined measurement-based care earlier, you defined it as a way of collecting information, collecting info on outcomes as people come in for visits and things like that. Do you see an expansion or change in what's able to be collected, or what do you see as a future path or future state for measurement-based care?
Yeah, I'm actually very excited about the big data psychiatry. I know the big data word probably is too old now, but I think that the digital psychiatry has a great future, and by that I mean like yes, these tools where we can collect information from the patients, whether it's patient generated or passively collected from patients, that can go into some clinical decision support system and guide treatment, and also be a proof of good treatment being provided and measure outcomes. I think that's a great future. So I think the next step really is on passive data collection. So this would be like either activities from smartphones that we can collect on whether patients' movements or their text messaging habits, or there's more advancement going on right now about using NLP for voice biomarkers or even facial expressions during therapy. So I think getting all that objective information, which can talk about patients' current snapshot state, or then we can look at measuring those as outcomes, would be great. I think digital psychiatry has a great opportunity for therapists and psychiatrists to get windows on how patients are doing in between appointments, right? And on their behavior, especially with many of these passive data collection opportunities. So I'm looking forward to that future, and I think that's probably the future of measurement-based care too.
Excellent. Well, naturally, working for Wobot, we of course appreciate that vision of the future as well. And so we've talked about that overall business perspective, the future, and the clinical perspective. But now it's time for you to get a magic power. We give this to every guest, and it's the ability to snap your fingers and one element of healthcare changes. If you could snap your fingers and make one broad sweeping change, what would that be?
Well, for somebody who's practicing mainly in New York, and I see the problem with access of care, especially to the population that's actually either commercially insured or have any kind of insurance, I wish we could solve the problem of more people being on par with payers, and we could provide proper access to the millions of people in our communities who do not get access to care in a timely manner, primarily because their insurance is not being accepted. So I think if we could solve for that, especially that's a big problem in New York. Yeah,
absolutely huge. And honestly, I part of my work outside of Wobot is being a fellow of the NYU McSilver Institute for Poverty Policy and Research. And I live in Detroit, but it was extremely eye-opening to see the many healthcare challenges that are faced in New York City. But Manish, I really appreciate having the opportunity to learn from you. But it also, I think a lot of people from in the audience, one thing that we're starting to do now is also ask, like with you as a leader who's made major changes and brought on innovations and things like that, who do you look to, or whose research do you like the most, or what are some examples of things that you like to follow to stay up to date and find inspiration for the types of change that you like to make?
I don't know if there's a one person or one resource that I go to. I am, you know, I feel like psychiatry has been ever changing since I've been in the field. When I started out, it was this, atypical antipsychotics and like the other Me Too drugs and this antidepressant but the field was really not moving. And then, things come in like use of peer specialists, right? And a new discipline, people with lived experience, and they are providing treatment, and they're becoming a big part of providing treatment. Now I'm very excited about digital psychiatry. I think, things are. So I don't know if there's one place. I stay close to the American Psychiatric Association. I'm part of a think tank called a Group for Advancement of Psychiatry. Mm-hmm. Mainly, I like to come to conferences like this and just meet with other thought leaders and stay connected. I don't know if there's one place to go to.
You did mention the Future of Mental Health Healthcare Summit. I'm sure they appreciate that too. So, thank you for sharing your background and your journey. And for the folks who have listened and they're like, I want to see what Manish is up to. What's the best way for them to follow or keep in touch?
I'm on LinkedIn mainly now. I used to be on Twitter or X. I'm still there, but I'm not that active there. Otherwise you can find me and reach out to me at Northwell.
Okay. Well, we'll very much flash his name on the screen and put it in the show notes so that you can find Manish and connect. He's an XX member, so don't go looking there. I just had to throw that one. You can edit that out if you want. But really appreciate everybody sticking around for this conversation. I would say that if you want to get some different perspectives, like we really wanted to focus in on practicing clinician perspective for this one. There was a great conversation that we had with Melissa Riley on the payer perspective. She's the Chief Strategy Officer at Cigna, Chief Strategy Officer at Ever North Behavioral Health Services, and we'll be flashing that on the screen for those who would want to see that one next.
Thank you for having me.
Thank you very much, Manish.